I'm talking to you from Sydney at the moment, and in the evening for us at the moment, it's 9 p.m., so getting close to the end of our day. So as Dr. Park mentioned, I'm originally from Egypt, and this is sort of where I grew up and where I started my dental journey. I did my undergraduate degree at the Cairo University Dental Hospital. And then I was lucky to be a part of the orthodontic program at Cairo University for about 2.5 years. And then I got accepted at the program in the University of Sydney. And this is when I then moved to Sydney in 2005 to start the training with Professor Darren Delilah, who some of you might know. It's a very nice program, and I was very lucky to be part of it. And after that, I stayed in Sydney and started a practice in Chatswood. We've had this practice now for over 10 years. And we have a lovely team that works with us. And as you all know, with orthodontics, it's a big team effort to deliver the services for our patients. And so I'm very glad to have an associate working with me, Dr. Anastasia. So it's good to have someone you can share some of your sorrows with, I guess, in a way. And we're very proud that we've 3 or 4 weeks ago now, we've just started our new practice, also in Sydney, but in a different suburb to Chatswood. So we now have 2 branches. This is our newest one. We've tried to spend a little bit of time during the COVID lockdown to design it in a slightly different way. And now we're very proud to start working there. These are our little surgeries with the glass separating compartments, and very pleasant working environment to be in. So we do like technology. I tend to use a lot of 3D technology, a lot of aligners, a lot of Lingual. But today we're probably going to focus more about the use of TADs. In particular, my go-to system is the benefit system. So we'll talk a little bit about where that fits in the management of maxillary deficiency. Now, we tend to use it in many different aspects of maxillary deficiency, but my focus today will be on class 3 malocclusion and maxillary protraction in particular. The benefit system, as you probably know, has been invented by Professor Benedict Films, one of a really good friend and a real inspiration. And I'm very, very lucky to have met him almost now 10 years ago and been introduced to this system, which has really changed a lot about how we practice. I do find, and I used to find even as a postgrad, that class 3 malocclusion is one of the more difficult ones to manage in orthodontic practice. And if we break it down, we're going to find that in class 3 malocclusion, even though historically we used to call it prognathism, actually a large mandible only is not the most common type of class 3 that we will find. In fact, the majority of class 3s are going to present with a component of maxillary deficiency, and some will have a maxillary deficiency and mandibular excess. So managing maxillary deficiency becomes quite important when we're talking about managing a class 3. And for a very long time, it seems to be that the face mask, when combined with maxillary expansion, was the go-to method. And even though the results with the face mask are reasonably good, because what you're doing is you're trying to restrain the growth of the mandible, while at the same time stimulating the maxillary sutural growth to come downwards and forwards. There is enough literature now to say that early protraction with the face mask is really going to be very important for us to consider, because it can reduce the need for orthognathic surgery. And this is a very good randomized controlled trial from the UK, which was published a few years ago now. I think it has really sort of puts the message down that, with class 3, we've got to be taking early intervention reasonably seriously now, because the evidence does suggest that if we intervene early, we can reduce the need for orthognathic surgery. And in their study, what they looked at was those children who have received face mask early versus those who haven't. And then they assess them to see whether they would be considered at, at the grown-up age and an adult age to be candidates for orthodontic surgery or not. And so what they found was those who've received early treatment were less likely to need surgery, whilst in the no early treatment group, most patients actually classified as needing orthodontic surgery. So I think early class 3 protraction face mask therapy can be now considered as a way to reduce orthodontic surgery or the need for it. But I think the face mask is not, it's got a lot of limitations, and a major limitation in my opinion is the fact that it is an extra oral appliance, which is not so appealing for a lot of patients. But another aspect is the fact that the window of opportunity for good result is narrow. Ideally, we want to be intervening before the age of 9 years old. And sort of that gives you a relatively narrow window of opportunity if we don't see this child in time. And that's because sutures become more interdigitated with age, and so they become less responsive to the protraction forces. So timing is everything when it comes to these cases. Another aspect is in older patients, they potentially won't be as compliant with wearing a face mask, so that can also reduce the quality of their result. But I think the major disadvantage in the tooth-borne face mask is that it is a tooth-borne appliance. Because if we were to look at what is the objective behind this treatment, well, the objective is maxillary growth stimulation. But what we are doing is we are placing an appliance on teeth. And in this case, mostly teeth in the mixed dentition, where the deciduous teeth are starting to also prepare for shedding. And we know that teeth respond to constant pressure by tooth movement. So what we are doing basically is trying to fire a cannon from a canoe. There's not really sufficient anchorage in that respect. So what you find a lot of the time when you remove an expansion appliance after treatment, it actually comes out with the teeth. And so you'd have to then question, well, how well was the anchorage working in the first place? But I think also one of the major limitations in face mask is that you will see most of the literature suggesting that patients are required to wear the face mask 14 to 16 hours a day. And I very quickly learned that in Australia, very unlikely that in Australia, children are going to wear a face mask 14 to 16 hours a day, simply because we have good weather. Children are very active, they play a lot of sport, and so it's unlikely that we're going to get that compliance. And in recent years, there's been some innovations, two in particular, that have really changed this concept. One is from Professor Eric Liu in Taiwan, which is the repeated, or the ultramic protocol, which is basically repeated rapid maxillary expansion and contraction. And the aim is to disarticulate the maxillary sutures to make them more responsive to protraction forces. And he was able to show up to 5 millimeters of skeletal protraction, even in the older children of 11 to 14 years old. And basically what we do is expand, contract for about 9 weeks, and then start the protraction. And the aim is to transform the sutures of someone who's a bit more mature, 12 to 14 years old, to that of someone who's more responsive, who's a bit younger. So the other, and I think this probably was the main game changer in skeletal anchorage, because skeletal anchorage really offers us a way, and this was Hugo de Klerk's introduction in 2008 and 2009, that you basically are targeting the area of the problem. You're running your forces directly to the jaws, actually doing true orthopedics. And when I went to the benefit course with Benedict and Professor Drescher, it was really made very good sense, because one of the things that we noticed that we do need expansion for a lot of our class 3 cases. So having the implants support the expansion made really good sense. And so these two approaches have really transformed how we do class 3 treatment. And at that time, that was in 2010, we put together a protocol at the University of Sydney to see if maybe we can try and combine these two concepts. And so the idea was to combine ultramic with skeletal anchorage, and also maybe eliminate the need for flap surgery by using mini screws in the mandible instead of skeletal plates. It was a prospective study, relatively small, with 14 patients, with the average age 12 and a half years old. So what was done there, they received 2 benefit implants in the palate and 2 mini screws in the mandible, and then a rapid maxillary expansion with a bonded appliance, and then an indirectly anchored lingual arch to the incisors, and then elastic wear after a protocol of ultramic for 9 weeks. What was interesting was that the response was reasonably quick. So the correction happens in an average of 8 and a bit weeks. And the maxilla moved forward approximately about 3.3 millimeters, which is twice as much as what you would expect, for example, with a face mask in that age group, in about a third of the treatment time. So here's one of the young ladies from the study, and you can see that the profile has significantly improved. If we compare this to what other studies have shown, we'll see that in the Sydney study, the skeletal effects were still not as good as what you would see with, for example, the de Klerk protocol with the BAMP method. But it's definitely better than using a two-spawn face mask. But when we look at the treatment time, the response, most likely because of the ultramic, was significantly faster when we looked at the protocol used in this study. And this is actually published down the Progress in Orthodontics, been published a couple of years ago. And it's an open source journal, so you can download the paper at anytime you wish. The problems with this setup, however, is because the indirect anchorage, especially in the lower, there was definitely some dental compensation with retroclination of the mandibular incisors, some maxillary molar extrusion, and so it wasn't really ideal. Now, in our practice at the moment, what we offer our patients is usually mostly skeletal base, and mostly one of the 2 options you see in the middle. It's going to be a hybrid expander in the maxilla, and then we're going to select whether we're going to use mini plates in the mandible for class 3 elastics, or we're going to wear a face mask. These are usually the 2 main options that we use. And that's because sometimes you're going to find children who absolutely reject the face mask, active lifestyles, or it's not really going to be suitable for them. So that's a reasonably popular method in Australia in particular because of that. But you can also get some kids who are willing to be compliant with the face mask. And sometimes we say we're going to try with the face mask, and if you don't succeed in wearing it, maybe we can then go ahead and place a mini plate. So this was one of our first and early experiences with the system. And a 10-year-old with an anterior crossbite and a class 3 skeletal pattern, negative A and B, and you can see that there's an element of maxillary deficiency just because of the amount of crowding we can see in the maxilla. So the plan was we're going to place 2 palatal implants. We're going to use expansion and protraction with a face mask using the hybrid expander. But he then said, at the day we were fitting the appliance, I'm not going to wear this. But hang on, remember we discussed this? Nope, I will not wear my face mask. And so that's when we decided, okay, we're going to go maybe with the alternate method, which is the method presented by Benedict Wilms and the group in Düsseldorf, which is using the mentoplate approach. Now, the mentoplate can be placed earlier than the bollard plate because it goes under the incisors and it does not necessarily have to wait for the eruption of the canine. So it's a larger flap procedure, but it allows us to start the treatment as early as 8 years old. Now, in his case, he was 10, but that didn't matter too much because the canine had not erupted yet. So we decided to go into this method. Now, at that time, we didn't have mentoplates in Australia. They weren't approved to be used at the time. So we used a conventional trauma plate, which was then fashioned in a way to fit under the incisors. Started with expansion, removed the face mask hooks, and then proceeded with the class 3 traction. Corrected reasonably quickly in 4 months, and then we obviously continued for about 10 months to achieve the correction. So we managed to get a reasonably good skeletal response. Maxillary advanced downwards and forwards. The mandible slowed down and moved downwards. And very little dental side effects. And this is the key here, is that no side effects on the maxillary or on the mandibular teeth. So that started to become a mainstay in the practice, and we improved a little bit on the protocol. So young Thomas here presents with an anterior crossbite again, a class 3 skeletal pattern, again a reasonably large skeletal discrepancy with a -2 A and B angle. And then after 10 months of elastic wear, we start to see, sorry, this is actually just at the start of the treatment there, just a little bit into it. What I wanted to show you is we use regular trauma plates. We do not use any of the proprietary mentoplates or bollard plates because, number one, they are expensive and they're not available in many of the surgical theaters. So that limits who can get this treatment. So we just use a conventional trauma plate, and the way we then do it is we just convert it into a hook with a high-speed handpiece. So it's a reasonably quick procedure, and that makes it much more affordable and less expensive for the patient. And we just add some flowable resin just to make the hooks less sort of irritating for the patient's lips. Because every surgical theater in the country is going to have trauma plates. And we also stopped using one plate. We tend to use two, so that the surgeon has a little bit more freedom in where they place them. They can still place them away from the developing canine, but they have a little bit more freedom in terms of how they position them so that they can get the best possible quality bone for the placement. So this is then after 10 months of elastic wear. Actually, sorry, more like 12 months of elastic wear. And you can see that a significant improvement in the skeletal pattern is evident. And it's really a nice change. The AMB is now +4 degrees. And when we look at the cephalometric superimposition, you can see that a significant downwards and forwards growth of the maxilla, and with little vertical change in the mandible, which is very desirable. And again, no significant dental side effects, so no proclination of the incisors. So as part of our research project at the University of Sydney, this is one of my projects, we compared the hybrid expander and the mini plates approach with the conventional RME face mask in a matched control group from the University of Ankara in Turkey. And so we had 18 patients with an average age of 10.5 years. compared with 19 of our patients with the hybrid expander and mentor plate and elastics. And the results were really interesting. I mean, you can see that at the level of the SNA, there's a significantly larger maxillary protraction over the SNA. The 8-point comes more forward. Not such a huge difference at the level of the mandible, but the overall skeletal response is significantly greater when we are using the skeletal anchorage group. But comparing that to the dental effect, and sorry, the other thing that's quite evident as well is there's also no vertical change when it comes to using the skeletal anchorage in that case. So not as much opening of the mandibular plane as you would get with your conventional face mask. At the level of the teeth, definitely a big difference in terms of upper incisor proclination with the face mask was much greater and almost non-existent when it came to the skeletal anchorage group. Another very interesting finding is that in the skeletal anchorage group, the lower incisors tended to advance a little bit, whilst obviously they retroclined with the face mask. And that advancement is interesting because that really doesn't seem to happen in many class 3 mechanics. But sometimes, families or patients will reject this idea of having a flat procedure and an anchorage plate. And this young man here is only 8 years old. His AMB is about -1.2. And in those cases, we actually do encourage them to use a face mask, but my protocol is to only ask them to wear the face mask to bed. Because I do feel that if we ask patients to do something that's achievable, that can fit within their daily routine, they can do it. But if it's something that's like, 16 hours a day, well, they think I can't do it. So they just don't do it at all. And we use, again, the hybrid expander setup. In most of our cases, I prefer to use a cone beam CT to actually decide where I'm going to place the mini screws. Because we are aiming for the best possible available bone, which we know is usually found in the anterior palate. But the other thing that's useful is to try and aim for bicortical engagement. So try and aim also for that cortical bone at the floor of the nose, because that gives us much better anchorage. It's a very different placement to what you will see with the MSC or the MAPI appliance. I do find that when I look at some of the setups with this appliance, I find that the TADs don't seem to be in an area that we would consider to have a lot of bone, at least based on most of the CBCTs of patients that I have seen. The bone seems to be quite thin in those areas. So we'd like to follow the protocol of placing the TAD in the anterior palate. And this is a study that came out of Düsseldorf. And it clearly shows that in CBCTs, the best bone you are going to find in the palate is in the anterior region around the line of the third Ruge. So that's where we're going to place our TADs. Start with some expansion. Don't expand maybe so aggressively anymore, mostly a little slower. And the patient is wearing the face mask. And then afterwards, we are going to be then using a retainer. And I prefer to use a skeletally born retainer. So this retainer is then reasonably comfortable, doesn't interfere with the space of the tongue, and doesn't require too much maintenance. And you can see a significant change in the profile. When we look at the cranial base superimposition for his CBCT, what you're going to see is, again, a significant change at the level of the maxilla, and that goes all the way up to the level of the orbit as well. And the cephalometric superimposition will give us a good idea as to how much skeletal changes happen. But again, what's also quite interesting is the dental change. In this case, because we expanded in the absence of crowding, we actually got a bit of retroclination of the upper incisors as opposed to proclination, which we see mostly with our tooth-borne appliances. So what we then did is we compared the hybrid expander and face mask when only wearing to bed to an RME face mask when worn or instructed to be worn 16 hours a day. So we compared 18 class 3s with a conventional face mask versus the implant-borne expander worn to bed only. Similar to the previous one, again, skeletal anchorage group seemed to show a significantly higher maxillary protraction as opposed to the tooth-borne group. Very similar effects on the mandible, but then the overall skeletal change significantly higher in the skeletal anchorage group. Now, looking at the level of the teeth, let's have a look. Significantly, almost no dental side effects pretty much in the maxilla in the group that had the mini implant-borne expander, whilst you have a lot more proclination and dental side effects in the group that had the expander. Now, is one of these protocols better than the other? So we know that skeletal anchorage might be helpful, but is one having mini plates in the mandible, is that going to perform better than if these children are wearing a face mask? So this is from the group in Düsseldorf, which I helped with. And if we have a bit of a look here, it's a really interesting comparison. So very similar age, very similar malocclusion, 17 and 17 cases. And one was instructed to wear the face mask 14 to 16 hours a day. The other one is wearing full-time elastics, 200 grams. And interestingly enough, the results show really no significant difference in terms of the protraction of the maxilla. But what was interesting was the face mask group seemed to drop more in the SNB. And that is most likely because you can see they actually experience more backward rotation of the mandible. So if you looked at the protraction of the maxilla was comparably the same without dental side effects in both groups. But if we're using a mini place in the mandible, we're going to have greater vertical control. And so this could be a better treatment in those cases where we have more need for vertical control, like high angle class 3 cases. So do we do routinely TADs in children 8 years old? Absolutely. And I don't see any reason not to, because it makes perfect sense. If we want to do orthopedic treatment, then the problem is not the teeth. Then we need to target the jaw. And this is my daughter. So when my daughters, actually both of them happen to have a class 3 malocclusion. So Hannah got her TADs in. She was 8.5 at the time. One.
It was quicker than mine.
So this is a new
Different.
driver.
Phew. I don't know, look at you. I might have to be screwed in.
Mummy was going to get jealous. It's a little bigger this week. Thank you. And then you can see that the situation didn't seem to be too stressful for her. It's all about how the case is managed from the outset, from how we explain it to the child, how we explain it to the parents, and how we get them set up. So I think it's not so stressful. I think we're the ones who tend to be a bit more stressed about it than the children themselves. With Hannah, we actually decided to try to use 3D printed appliances, and so we did a 3D scan, got that file over, and we then designed the appliance with you guys might know Simon Graf. So Simon is the one that introduced us to the 3D printing now 5 years ago. And that's really been a transformative thing for the practice, because then the appliances are going to be so neat. They're going to fit without the need for separators. No need for any impressions, just all from with a one scan. The appliance is then cemented. Because of the 3D printing, you can make it really well adapted to the palate. And then Hannah started her class 3 elastics. Now, because when it came time to treat Mariam, we'd already found out from the study that we did with Düsseldorf that, well, works just as well if they're compliant with their face mask. So Mariam, my youngest daughter, she then went with wearing her face mask. So that's both the girls there. They've got their bone anchored expanders, one with class 3 elastics and one with face mask. Now, just a point on 3D printed expanders, because that's something that we are probably seeing more and more of. Just remember, when somebody's saying we're doing 3D printing, these appliances are not all created equally. Now, some labs tend to basically just print a shell around the teeth, and then they go and still manufacture the rest of the appliance conventionally, while others will 3D print the entire framework. And they tend to, in my opinion, be a little bit more customizable. So all the parts here are laser melted except for the expansion mechanism, and there is no model printed. Whilst the other method would be basically only the pads are 3D printed, but then the rest is just soldered on a study model. So they still have to make a model and then they solder onto that model. Different technologies. Now, all of these methods are compliance dependent, and that was something that I was struggling with in private practice, where sometimes you cannot help but the child is just not wearing the bands. Even though we don't need a headgear, they still don't wear the intraoral elastic. So what do? So that prompted the latest project which we just finished, which was basically, can we eliminate the need for patient compliance? And can we also eliminate the need for flap surgery? And in Australia, most of these mini plates in the mandible are placed under a GA. So that's, again, also maybe an intervention we want to try and avoid. And now this was inspired by this paper by Eric Liu in 2005, which was a tooth-borne orthopedic maxillary protraction appliance with intraoral springs. So we came up with this class 3 corrector design based on 2 palatal implants. And then we designed a cantilever bite jumper, very similar to the Herbst appliance in reverse. So this is the lower component. And so we have the upper component has the cantilever arms, the lower component has a lingual arch. And then they are both connected together with a bite jumper with an internal spring, which is basically a modification of the power scope, which is made by American Orthodontics. And so the idea is we are pushing the maxilla forward, distalizing in the lower, and that is anchored to palatal implants to eliminate the dental side effects on the maxilla. So we enrolled 20 patients in our pilot study, our prospective clinical trial, and all with class 3 malocclusion with maxillary deficiency. And so we place the 2 palatal implants. We start with maxillary expansion, and then once the expansion is completed, we place the bite correcting spring. And then the spring can be reactivated by adding those little shims to the side, and gradually the malocclusion corrects until we have a positive. So the reactivation happens by compressing the spring further by adding the shims to the sides. So we went from there to there in about 10 months with no compliance. And that's, I think, the main advantage we found from this device. And then you get also a significant amount of maxillary protraction. So our preliminary results are telling us that the appliance was reasonably well tolerated by the patient. We achieved a positive overjet in all of the patients in about 10 to 12 months. It mostly came through maxillary protraction and some dental changes in the mandible. The maxilla had no dental side effects, but the mandible showed lower incisor retroclination and significant tipping of the lower molar, which tipped distally, which is to be expected, I guess, because you're just leaning on them 100%. So when we compared that to a tooth-borne face mask, what we found was that we did get more skeletal protraction in the bite corrector group. We also had less of an effect on the mandible in that same group. The overall skeletal correction was better. And the other thing is there was no backward rotation of the mandible. So that's, again, could be a favorable outcome, especially when we are considering cases with high angle. Looking at the dental side effects, no dental side effects on the maxilla, but also both of the groups had retroclination of the lower incisors. Now, the appliance does have problems, and one of the problems with the appliance is the fracture. So because the mandible doesn't really readily fall backwards, like it can posture forward in class 2 correctors, but it doesn't really push back very easily. So in some cases, we found that they did fracture those protraction arms, and sometimes the springs themselves fractured. The most annoying problem was the fact that they tended to sometimes unscrew themselves, and that, I guess, happens also if you're using this appliance for class 2 correction. You'll be familiar with this problem. They can unscrew themselves, and that can be a little bit annoying sometimes. So we suggested that maybe we consider having the threads on that appliance to screw it into place, maybe having reverse threads. I think that would really help. So when we don't have COVID and we can actually go out there and do stuff, I really enjoy doing triathlon. I used to enjoy doing triathlon, and in Australia, and you might be familiar that our oceans are very exciting places. I tend to swim with a group of people here in Sydney in Bondi Beach, and one weekend I missed my swim, and then I looked at their Facebook and I saw this picture. Now, what we do is we swim out all the way, and then we dive down to touch the shark nets. No one really, thinks, oh, we're not going to see a shark there. And these guys did this and went home, didn't realize when they actually downloaded the photos, they saw that there was a shark in the background. In fact, the picture made it into the local paper, and people were wondering whether that photo was doctored or whether it was real. So what about more severe class 3 cases? So let's have a bit of a look. So with moderate class 3s with skeletal anchorage, we're getting good results. What about more severe cases? So this young man is 9. He's got what we would say severe class 3 is also because he doesn't have a functional shift. So this is a true skeletal discrepancy with severe maxillary deficiency. So when you are faced with a situation like that, would you treat it? And when I was faced with that situation, I didn't have as much experience with skeletal anchorage back then as I do now. And so I was querying, well, what do we do? And I thought, well, you know what? If it was my child, I probably would try. I definitely would not try a face mask because he's a little bit too old, he's too active. But maybe we should go straight away to what I thought at the time was our most efficient method. So mini implants in the palate, class 3 elastics, and we actually used an alternating expansion and contraction protocol as well. This is after 10 months, we started to see significant improvement. And one of the things, the comments we got from the parents was that he actually now started to get cheekbones. And, the mother was so happy with that development. And then gradually we got him to a positive overjet. It took 14 months to get to this. The first time we had a positive overjet, which had a significant impact on the profile. So I went and traced up his lateral ceph to see, well, what actually happened? What did we do? So he's still actually, if we look at it very strictly, he's still a little bit of a skeletal class 3. He's come from an A and B angle of -5 to a 0, but that's still probably a class 3. but a significant improvement and no dental side effects on the maxillary incisors. So we got from here to there in 14 months. Now he's now 10 and a bit years old. What do? We can't stop now because he's going to grow. So we continued for 1 more year. Now this is him going into high school. So a significantly good change in the profile. And now we did a follow-up CEPH. This is after a total of 28 months of maxillary protraction treatment. Now we've got a positive A&B of 2 degrees. He's now a skeletal class 1. And if you looked at how much the maxilla protracted from the lateral cephalometric superimposition, it was almost 11 millimeters of maxillary protraction with no dental side effects. And again, this is what we see in some of those severe cases. The lower incisors will advance sometimes and procline a little bit. And I think that's because the way the tongue pressure changes. And they can actually feel the lower incisors touching the tongue, and that can actually push them a little bit forward as well. So now comes the question is, well, how are we going to retain this? It's still going to grow. So we took out the expander and we decided we're just going to retain it the same way we treated it. So in the latest follow-up, we then did a rigid 3D printed rigid transpalatal bar. The 3D printed material, the rhymanium, is very, very stiff. So when made in that thick cross section, it's going to allow very little flexion, anchored to the same palatal tabs. And then we're asking the patient to wear some elastics as much as he can. We normally said mostly at night if you can, but if you can wear it a little in the day, please do. And he managed to hang on to the correction. And this is him now, 2 years of retention. He's now well and truly grown up. And I think we've probably managed to avoid surgery for him. So that is the case progression over the long term. Now, a question that was raised about doing class 3 correction like that is, well, is that going to somehow negatively impact the airway? Is it going to sort of choke the child because we're sort of holding the mandible back? And even though I don't think that would necessarily be a concern at all, but it needed to be studied because, you know, the airway is a hot topic these days. And so the group at UCLA with Tung Nguyen had a look at this, and their controls were a group of untreated class 3. So they look at the treated with Dr. de Klerk's protocol versus untreated class 3s. And they looked at the airway volume in the pharyngeal area. And what they found was that the subjects that were treated actually showed an increase in the airway volume in the oropharyngeal dimensions. And this was, however, not statistically significant, to be absolutely sure about this. And then the airway volume and the minimum cross-sectional area was similar in the BAMP subject and the untreated control. So it's really not necessarily a detrimental thing for the airway. But because airway, you know, airway is sort of a big deal. It always has been, actually. We kind of knew all about it in ortho for a while, but it's a really hot topic in dentistry. So we're going to talk about, we need to practice airway-friendly dentistry. And I think it's always a good start to start with airway-friendly dentistry, avoid things like that, for example. But all jokes aside, upper airway obstruction is a hot topic, and we are in a prime position to be able to find out and ask people about this. You know, do you have any of the signs of sleep disordered breathing, such as snoring, noisy breathing, reflux, bedwetting? We use attention span in the day. Even just things, basics, things like mouth breathing can be a really big giveaway. And when we're looking at upper airway obstruction in children, well, obviously there's adenotonsillectomy, but there's also rapid maxillary expansion. We can actually contribute significantly to the treatment of upper airway obstruction with the help of some of the medical colleagues that we have, because adenotonsillectomy plays a major role as well as pharmacological interventions. So I like to say that because we sometimes think that dentistry can fix airways. We can't fix airways. The airway is very complex. You know, we can get central sleep apnea, for example, or bad sleep hygiene. Kids go on screens before they go to bed. We can't change that. And then when we're looking at the upper airway, like in the nose, well, you know, there could be allergies, could be deviated septum, enlarged turbinates, sinusitis, gastroesophageal reflux. Yes, we can help with one aspect, which is the narrow nasal passage. Then you've got the adenoids. Orthodontics can't fix that. And then going back further down, again, you know, there's very little we can do aside from mandibular retrusion and narrow palate. So it's very important that we don't act alone when it comes to upper airway obstruction. But we do know that the nasal airway does change with maxillary expansion. So this is a good thing. Now, why does that happen? I think there was two particular reasons why maxillary expansion can help. One is obviously when we expand the palate, the nose is attached. Both are coming in the same bone, and so we get some widening at the level of the nose. You get increased nasal volume. You get bony infill, and then we get a better or a drop in the resistance to breathing from the nose because we got a wider nose. But what also I think happens when we do this expansion at the level of the palate, we're also going to get an increase in the palatal volume. And when you get an increase in the palatal volume, that's more room for the tongue. And so that tongue can clear out the pharyngeal airway by moving up and forward into the palate. I think we can contribute in two possible ways. Now, obviously, there's a whole heap of studies about this, and especially this is a really good study with looking at rapid maxillary expansion in children with OSA, and you can get almost 100% improvement provided, number one, you're using a fixed expander, not a removable expander, and number two, there is absence of adenotonsillar hypertrophy, so that's been dealt with or it doesn't exist. And the other thing is we have to confirm these results with a sleep study because otherwise we don't know if this has worked or not. And there's a lot of research now that would suggest that there will be improvement in AHI and oxygen saturation with maxillary expansion for kids with upper airway obstruction. So which one is better, tonsillectomy and adenoidectomy or rapid maxillary expansion? This is a good study to look into that, and they actually did a crossover design. So they had a group of children that had adenotonsillectomy and then had a repeat sleep study and then had an expander. The other group started with an expander, then had a sleep study, then had adenotonsillectomy. The interesting finding here is that most children seem to need both intervention to normalize their sleep study results. Okay, well, so we know maxillary expansion can help. Is there a particular expander that's better? So for example, what about a removable versus a fixed expander? It is my personal opinion that removable expanders are terrible for airways. And that's because a removable expander, and you can see sometimes people even put them in the lower jaw. I saw this child, it was prescribed 12 to 24 months of treatment with this device to help improve their airway. My feeling is that appliance like that is actually choking the child in their sleep. Think about it this way. If you have an appliance that is occupying the palate, where is the tongue going to go? The tongue has to then sit low and back. You add to that a plate in the lower jaw, which is going to obstruct the tongue even further. So all we're going to do is we're going to put all these plastic blocks in the patient's mouth, which are going to push the tongue backwards and literally choke them. So I'm not in favor of removable appliances when we are talking about children with compromised airways. And I think a 3D printed fixed expander is probably better. But what about bone-borne expanders? Is there a benefit? And the answer is a resounding yes. And this is a randomized clinical trial that came from Germany. And if we have a bit of a look at what they compared, they looked at conventional tooth-borne expansion versus hybrid expansion. And then they did a rhinometry pre and post expansion. The results were quite interesting. Obviously, there's an improved nasal airflow in both groups, but significantly more improved in the group that had the bone-borne expander. And so the conclusion of the study is that you should be considering the effects are actually similar to those of a decongestant nasal spray. So if we are looking at a child suffering from airway obstruction, upper airway obstruction, and it may be prudent to consider a tooth bone-borne appliance instead of a conventional tooth-borne design. They will both expand the arch, but one has a significantly higher impact on the nasal airway. So why does that happen? I think I don't know if it's self-explanatory, but what I'm going to try and show you here is the pattern of expansion changes. When we are expanding with tooth-borne, we get a lot more bending in the dental-alveolar process. When we place some titanium implants in the palate, the expansion is a lot more closer to the floor of the nose, and it's a little bit more parallel on the skeletal level. So you will get a greater increase in the nasal volume. You may actually get no real difference at the level of the dental arch, but you will get a significantly bigger change at the level of the nose. Our friends in Brazil here just recently completed a randomized clinical trial just looking at that. And again, looking at the skeletal measurements alone, it was very clear that when we look at the nose, that the skeletal effect and the nasomaxillary structures, especially around the nasal cavity, was greater when we're using the hybrid Hyrax as opposed to the tooth-borne appliance. So when we have a look at this young man here with diagnosed sleep disordered breathing, he already had adenotonsillectomy and his symptoms were not fully resolved. Narrow maxilla, classic sort of situation where you'd expect that a narrow maxilla would translate also into a narrow nasal airway. Hybrid expander and face mask. Expansion. The expansion happens at a higher level, so you get more bony expansion. You can definitely then see that the face of this patient looks very different to before the treatment. The difference between the two images is 14 months. Symptoms resolved, behavioral changes noted. Now, if we look at the level of the bone, what's happened here, this is the pre-treatment CBCT, and this is after. It's a massive change at the level of the nasal cavity. Not to mention at the level of the maxillary growth. We are wearing some face mask here as well, and that's because he's also maxillary deficient in the anteroposterior dimension as well. So you can see that the maxilla will also grow downwards and forwards in that sort of scenario. And then this is a few years later now, he's more grown up, and now the permanent dentition is erupting and he's maintaining his class 1 occlusion. So is there more evidence to support this? Yes. So this is a study from Sydney in conjunction with our Japanese colleagues. And if we have a bit of a look here, they compared 3 expanders: hybrid expander, Kellis expander, and the conventional Hyrax in a randomized clinical trial. And they looked at the nasal ventilation using a 3D flow simulation software. So what they found was, when we're looking at the hybrid expander, there is a significantly higher reduction in pressure in the nose, and airway velocity is also much more increased when we are using the hybrid expander. I was very impressed with how well the Kellis expander performed, I must say, because on the surface, you would expect it to be very similar to the Hyrax, but it outperformed the Hyrax significantly, even though both are tooth-borne. But if you looked at the maps of how the ventilation works, the blue means that it's flowing smoothly everywhere, and that's what you would like to achieve. And that seemed to be only achievable with the implant-borne appliance. So if we were to draw some conclusions, well, the hybrid Hyrax induced significantly greater effects in increasing nasal width. Excuse me. And a similar trend was noted in reducing pressure and maximum airflow. So this is usually our go-to appliance when we see children with a nasal obstruction. So here we have a young lady again with a significantly narrow maxilla, also a class 3 tendency, because I find maxillas seem to be mostly deficient in all 3 dimensions. And that will also then result in, crowding for the canines, narrow nasal passage there. Very narrow. This is actually difficult TAD placement, I have to say. This was not an easy placement, but when you can 3D print the appliances, let's have a bit of a look and see how narrow that palette is first. Wasn't an easy TAD placement. When with 3D printing, you can make these appliances fit reasonably well. And this is the appliance in place. And then we expand. Now see what's happened here is what's happened to the Ds, they actually shed as in the middle of treatment. And that will tell you that if this appliance was a tooth-borne appliance, there would be hardly any skeletal expansion in that area. So if we didn't have TADs, we would be mostly extracting teeth with the appliance, even though they seem to have enough root. So that's why you see things like that. And you don't really get a lot of expansion when this has happened. Now the appliance is out. And because I want the tongue to occupy the palate, she's not going to be given a removable retainer. We will place a skeletal retainer, and that way the tongue is completely free to sit in the roof of the mouth. So that was before, and this is after. And if we have a look at the level of the bone, that's before and that's after. That's a big change in the nasal passage. And also in terms of skeletal measurements, if we actually have a bit of a look at it, this is before, and at the level of the nose, we had a 7 millimeter increase in the skeletal width of the nasal cavity, which then if you look at in terms of bony change on 3D, it's a big change. That's the kind of level of change that we are able to achieve with these bone-borne appliances. So when I look at that, now I really don't like to call these expanders anymore. I don't think they do the same as what we get with our bone-borne expanders.
And your wallet.
Nick, give him your wallet. Or Paul, he's got a knife.
That's not a knife. That's a knife.
So I like to use the same analogy in a joking manner. Obviously, these are expanders, but maybe they're not as efficient as the other ones. But I would say that's not an expander. That's an expander. So just to finish off, we'll just show a little bit more of trying to combine some of these technologies in a bit of a difficult scenario. So we've got a class 3 edge-to-edge bite. You can see them. Severe bruxing is usually associated in kids with sleep disordered breathing, maxillary deficient, and we also have an ectopic first molar, which is compromising the second deciduous molar as well. Some serious crowding there with large incisors that are about to come in, and also that ectopic molar that's caused resorption of the second primary molar. So this is a situation where we have a small maxilla in all three dimensions and not so much dental anchorage to work with because our E is also compromised. What we actually would like to do is we'd like to expand. We would like to distalize the molar, and we'd like to move the whole maxilla forwards and downwards. Can we do this? Yes, we can. Now with 3D printing, we can actually be quite creative with our designs that maybe labs that are going to have to bend wire might struggle to deliver. So here we have an expander, we have protraction hooks, and we also have a distalizer at the same time. So this is the appliance in place. We start with expansion, distalization, and at the same time, the child is wearing a bedtime face mask. And then this is at the end of treatment. Now, how are we going to maintain this change? We need to somehow keep that molar back there, otherwise it will drift back where it came from. But you can see a very big improvement in the facial profile with the smile. Now, how are we going to stop it from coming forward? Now, the lab suggested initially to do that, and I thought, well, I don't want to lean on that E because I don't think that E is going to be a very strong tooth, and we do have two TADs. So we ended up making this as a skeletally born retainer. And what you can see there is the second premolar has slipped from underneath the primary molar and is already starting to erupt. Now let's see what's happened to the nose here. It's a big change. This is before and after. And the maxilla has come forward a long way from there to there. And we've created hopefully enough space that we're going to be able to accommodate for those teeth without any need for extractions in the future. So a big thank you for having me tonight from Sydney. I hope you have found this useful and you might be able to take home some of these tips with you into your practices. I